Hello and welcome everyone. Today we'll be discussing regarding vitamin D. This is going to be a long video where we'll be discussing the metabolism, the molecular mechanism of action, and various pleiotropic effects of this vitamin. So there has been a resurgence in the interest of vitamin D. Vitamin D deficiency and rickets has emerged as a significant global health issue. There is new evidence which highlights that the hormone's role is there beyond the skeletal health. The key functions of vitamin D are calcium and phosphate homeostasis, which is essential for the bone mineralization and prevention of rickets and osteomalacia. And it also has pleiotropic effects, which includes various biological responses like cancer inhibition, cardiovascular health, and immune modulation. So, first looking at the metabolism. Vitamin D synthesis and activation. It is synthesized in skin, that is vitamin D3 cholecalciferol, which is produced in skin from 7-dehydrocholesterol upon exposure to ultraviolet B radiations. In liver, the vitamin D3 is hydroxylated to 25 hydroxy vitamin D3, also known as calcidiol, in the liver. And then in kidney it undergoes hydroxylation to its active form, which is the 125 dihydroxy cholecalciferol or the calcitriol. So overview, the importance of each step is that the skin is the main source of vitamin D, which is affected by factors like latitude, season, and skin pigmentation. Liver hydroxylation produces the major circulating form, which is used as a marker of the vitamin D status that we check. Next is kidney, which converts the hormonally active form that exerts various biological effects. So what are the sources of vitamin D? The endogenous sources. The ultraviolet B exposure, sunlight exposure in the skin, is the primary natural source of vitamin D3. Factors influencing this synthesis are the geographic location, that is latitude, the season, the time of day, skin pigmentation, use of sunscreen. Now the example is, if you take a location like Srinagar in India, which is a higher latitude, there is significantly reduced vitamin D synthesis from sun exposure, especially during the winter months. Conversely, in the lower latitudes such as Chennai, vitamin D can be synthesized all the year round with adequate sun exposure. Then we have dietary sources, which are the natural being the fatty fish, salmon, fish liver oils, and egg yolks. In fortified foods are available in India, that is, it is commonly fortified, vitamin D3 is fortified with milk, yogurt, and some cereals as well. Often necessary for individuals with limited sun exposure, that is supplementation or dietary intake, particularly in northern parts of the India, especially in the winter months. Now the transport and storage of vitamin D. The transport mechanism is it gets transported through DBP, the primary carrier protein for vitamin D and its metabolites in the blood. The function is it binds to the vitamin D3 and the 25 hydroxy D3 with high affinity, facilitating their transport to the liver and other tissues. Transport to the target tissues. After hydroxylation in the liver, 25 hydroxyl is transported to the kidneys for further conversion to an active form or to other tissues for storage and action. Now, storage. Fat and muscles. Vitamin D is stored in the adipose tissue and muscles, acting as a reservoir to maintain the plasma levels during periods of long intake and reduced sun exposure. Now, release from storage, it is released and it is mobilized when needed to maintain a steady state in the blood and to maintain the physiological functions. The role of the carrier protein variants is that there are genetical variants which affect the binding affinity, bioavailability, and influence the individual's vitamin D status. Now, bioactivation of D3, there are very key steps over here. First is the liver conversion of D3 into 25 hydroxyl D3 by this enzyme, that is cytochrome P2R1. Here you can see the P2R1, which is causing the hydroxylation. This is your dietary intake. Next is the activation in the kidney, where the P24A1 converts it into 24-hydroxyl, which has an oxidative side chain cleavage, and the main active ingredient, which is P27B1, which does the 1-hydroxylation. Now the enzymes involved are first in the liver, that is P2R1, P27B1, which is the 1-hydroxylation, and regulation of the bioactivation is parathyroid has a very important role over here, which stimulates this P27B1 activity in the kidney, increasing the production of the active form, especially when it is in response to low calcium levels. So these are the stimulants for 125 hydroxylation. And next we have the feedback inhibition, where high levels of this active form inhibits its own enzyme and stimulates the other pathway, that is the 24 hydroxylation, which produces the inactive one. And finally you have these two methods of breakdown which are excreted. The next is the vitamin D receptor. Here you can see a diagram of the receptor. The vitamin D receptor is a nuclear receptor that mediates the effect of the 125 D3. Now the vitamin D3 regulates the expression of various genes involved in the calcium homeostasis, immune response, and cell proliferation. This is the structure, as you can see. The DNA binding domain. This is the DNA binding domain. It allows the VDR to bind to specific DNA sequences known as vitamin D response elements. These are the vitamin D response elements. Next, you have the ligand binding domains. This is the ligand binding domain, and this binds to the 125 hydroxyl D3 and causes conformational changes that enables interaction with other proteins and DNAs. Now, heterodimer formation, that is the vitamin D receptor, often forms a heterodimer with the retinoid X receptor to regulate the gene expression. This is the heterodimer form. Then the gene, it localizes to the chromosome 12 in the humans, and the VDR gene is evolutionarily conserved across many species, indicating that it has a fundamental role in the physiological processes. Next is the mechanism of action of vitamin D3 receptor. Now 125, the active form, binds to the ligand binding domain. The conformational changes that it brings about enhances the ability to interact with other molecules and DNA. Now the formation of the heterodimerization with the retinoid receptor is another nuclear receptor. Now the DNA binding to specific DNA sequences called the vitamin D response elements located in the promoter regions of the target genes. Now next is the gene regulation, where there is co-activation and co-repression. The activated heterodimer receptor recruits co-activators that like SRC1 or co-repressors to modulate a gene's transcription. The interaction with the upregulation or downregulation of the expressor target gene involved in various physiological action, including calcium metabolism, immune function, and cell proliferation. Next is there are various actions of the vitamin D3 through this receptor. Some are genomic actions, some are non-genomic actions. So first we will discuss the genomic actions, that are the direct regulation of the gene expression, as we can already discuss, that is the VDRE binding. Next is the transcriptional activation and repression. Next is the key genes and pathways that are regulated by vitamin D. By this are the calcium homeostasis, that is the gene involved in calcium absorption and bone remodeling. Immune functions, that is regulation of the genes that modulate immune functions involving antimicrobial peptides and cytokines. Cell proliferation and differentiation, chromatin remodeling and gene regulation. Chromatin state, that it influences the chromatin state, making it either more or less accessible to the transcriptional machinery. Next, we have the epigenetic modulations. So this receptor involves changes in the histone activation and methylation, affecting how tight DNA is wound around the histones, thus making the gene accessible for transcription or not. Next, we have the non-genomic actions. So a brief overview is there is a rapid cellular response. The non-genomic action of vitamin D involves rapid signaling events that do not directly alter the gene transcription. These actions are mediated by the VDR or other vitamin D binding proteins located at the cell membrane rather than on the nucleus. So the key non-genomic pathways are calcium channel pathway regulation, which are voltage gated or store operated calcium channels, activation of kinases. 125D3 activates various protein kinases like protein kinase C and mitogen activated protein kinase, that is MAPKs, leading to downstream signaling and effects. Next, we have the phosphatidyl inositide pathway, which is activation of this leads to release of intracellular calcium and modulation of the calcium dependent cellular processes. The physiological effects are muscle function with rapid effect on the calcium influx and signaling in the muscle cells, affecting their contraction and function. Immune response, that is modulation of the immune activity and cytokine release. Neurotransmission. Next is the most important role of vitamin D, that is the classical role on calcium and phosphate homeostasis. So coming to the calcium homeostasis, it affects the intestinal absorption, the renal reabsorption, the bone remodeling, and next is the phosphate homeostasis, which is again intestinal absorption, renal handling, that is it increases the absorption of phosphate in the intestine and excretion of the phosphate, balancing the phosphate levels in the body. Bone health, it ensures adequate phosphate supply to the bone mineralization, working alongside calcium to strengthen the bones. The regulatory feedbacks. Now the parathyroid hormone, that is low calcium level, stimulates the parathyroid release, which in turn increases the 125D3 synthesis, enhancing calcium absorption and reabsorption. Next is the FGF23, which regulates phosphate homeostasis by decreasing this 125 hydroxyl production and increasing phosphate excretions when levels are high. So, looking at first the mechanism of the intestinal calcium absorption. So, there is a transcellular calcium transport, as you can see in this diagram over here. You have the TRP76 channel. Here is the channel. Vitamin D upregulates this and epithelial calcium channel and facilitates the entry of the calcium entry into the intestinal epithelial cell. Next is the calbindin D9K. Once inside the cell, the calcium binds to these, a calcium binding protein that helps shuttle the calcium across the cytoplasm. Next is the PMCA1B pump, the calcium actively extruded from the cells into the bloodstream by the plasma membrane calcium ATPase. All of these being activated by vitamin D. Then you have a paracellular calcium transport, as you can see a channel over here. So we have tight junctions. When dietary calcium is abundant, it can pass through cells through these tight junctions. Now, vitamin D may influence the expression and function of the tight junctions, affecting paracellular calcium metabolism. However, how does vitamin D does it is not something which has been established as of now. Then we have compensatory mechanisms, that is alternate transporters. In absence of these channels and other transport mechanisms can compensate. Like under conditions with low dietary intake, vitamin D enhances the efficacy of the transport mechanisms, optimizing the calcium uptake. Then we have the renal reabsorption. Most calcium is reabsorbed passively along with sodium and water. In the distal tubules, active reabsorption is regulated by the vitamin D and parathyroid. Vitamin D enhances the expression of TRV5, facilitating calcium entry into the renal epithelial cells. And here also you have this calbindin D28K, which is similar to the intestinal one we have just seen, which transports the calcium within the cytoplasms. Now next we have the NX1 and PMCA1B. These transports actively transport the calcium into the bloodstream, thereby preventing their excretion. Next we have phosphate reabsorption. Majority again occurs in the proximal tubules through the NPT2A 2C receptors. Then you have regulation by the parathyroid and the FGF23. Parathyroid increases the renal phosphate excretion by reducing the expression of sodium phosphate cotransporter, and FGF23 decreases phosphate reabsorption and vitamin D production, balancing the phosphate level. Now, role of vitamin D over here is to enhance calcium reabsorption. Vitamin D increases the expression of the various receptors and transport mechanisms to facilitate the entry of calcium to the bloodstream. Indirect regulation on phosphate is through the FGF23 and parathyroid. Vitamin D indirectly influences the phosphate handling. So this is the handling that you can see. This is the proximal tubule, this is the distal tubule. In the proximal tubule, it acts by acting on these receptors, and this is how the phosphate enters and goes into the blood. The main job is in the distal, where the main regulation occurs, where you have this cal binding to E27 and the TRPV5, which makes the calcium enter and transport to the other end, where they are actively excreted into the bloodstream. And this is the phosphate pathway, where FGF3 is preventing phosphate and parathyroid is increasing the phosphate absorption. Now, what is the role in bone metabolism? Vitamin D plays a crucial role, and it helps in proper mineralization of the bone matrix. It ensures adequate calcium and phosphate levels, which are critical for forming hydroxyapatite and the mineral component of the bone. Vitamin D influences both bone reabsorption and formation, maintaining a proper balance. It acts on the bone cells, that is osteoblasts, which are responsible for bone formation. Vitamin D promotes osteoblast differentiation and secession of the bone matrix. And in the osteoclasts, it indirectly stimulates the osteoclast activity by promoting the expression of the rank L on osteoblasts. This binds to the rank on the osteoclast precursors, promoting their maturation and bone reabsorption activity. Now, regulatory effects. These pathways, that is the rank pathway, vitamin D increases the production of the rank, enhancing osteoclast activity. The osteoproteogerin, that is OPG, a decoy receptor of the rank, is regulated to balance the bone reabsorption and formation. Now, by regulating calcium and phosphate levels, vitamin D ensures that sufficient supply is there for the mineralization of the bone and its maintenance. The clinical importance over here is that the deficiency of vitamin D leads to softening of the bones in children and adults, which is because of the inadequate mineralization. Osteoporosis, where adequate vitamin D levels are crucial to prevent osteoporosis, a condition which is characterized by weak and brittle bones, especially in older adults. So, vitamin D has an absolutely central role in bone metabolism. Next is the pleiotropic effects. These are the main effects that we are looking nowadays. Calcium and the phosphate role is very established. These are the role which are recently being found out, that is its role on the multi-organ system and physiological impact. The key areas being immune system, cardiovascular system, cancer, metabolic health, and finally the neurological impact. So all these functions can be affected by vitamin D. We will see each one by one. So the mechanisms are gene regulation, that is the vitamin D receptor mediated transcription regulation, non-genomic pathways. So first we are looking at cancer. It has got an inhibitory effect on the cancer cells. Cancer proliferation is inhibited by the vitamin D, and the division of the calcium cells is reduced. Now, it promotes the differentiation of the calcium cells, making them less aggressive and more like the normal cell. It also causes apoptosis, but that is enhances the programmed cell death of the cancer cells, helping eliminate them. The mechanism of action is gene expression regulation. As we have already seen, the VDR activates and influences gene expression in the cell growth, differentiation and apoptosis. Anti-inflammatory effects have been seen where it is driving the progression and the cancer development. Inhibition of angiogenesis. It decreases the formation of new blood vessels that a tumor needs for their growth and metastasis. and it enhances the body's immune surveillance against cancer cells. Now, what is the evidence from the research? Regarding breast cancer, studies have shown higher level of vitamin D is associated with reduced risk of breast cancer and improved survival rates. In colon cancer, vitamin D has been linked to lower incidence and progression of colorectal cancers. In prostate, some evidence suggests that vitamin D might reduce the risk and slow the progression of prostate cancers. The clinical implications are vitamin D or its analog could be used as an adjunctive therapy in cancer treatment to enhance the efficacy of conventional treatments. It maintains adequate vitamin D level, can promote and prevent cancer prevention, particularly in high-risk individuals. Next is the cardiovascular effects. It has got an important role in the blood pressure regulation by modulating the RAS pathway. It reduces the stiffness and enhances the elasticity. And anti-inflammatory, antioxidant effects also affect the endothelial dysfunction. The mechanism by which it does is it modulates the RAS function, where the renin expression is affected. The endothelial function is affected by the vasodilation and the nitric oxide. Calcium regulation, which prevents the stiffness of the arterial walls. Next is the research. What evidence we have as of now? Regarding hypertension, higher vitamin D levels are associated with lower blood pressure and reduced risk of hypertension. In coronary artery disease, there is a link between sufficient vitamin D levels and lower risk of coronary artery disease. Heart failure, lower incidence is observed in patients who have been supplemented. The clinical implications being a therapeutic effect of vitamin D supplementation in all these groups, prevention of cardiovascular health by giving vitamin D and reducing the impact on coronary artery disease and heart failure. Next is the immunomodulatory effect. It affects the innate immunity, the adaptive immunity, the mechanisms being antimicrobial peptides which are enhanced, that is, which use the calcium, are stimulated by vitamin D. The cytokine modulation occurs, which regulates the cytokine levels. T cell differentiation is affected. The B cell function, that is the maturation and antibody production, is very much controlled by the vitamin D receptors. Now, impact of autoimmune is also very important. Multiple sclerosis, vitamin D levels have been associated with lower risk of multiple sclerosis and may reduce the incidence of relapse. The next is rheumatoid arthritis, where vitamin D can affect the rheumatoid arthritis symptoms and disease progression. Type 1 diabetes, same, reduces the risk of development of type 1 diabetes by modulating the immune regulation of the target pancreatic beta cells. The clinical implications being infection control is enhanced with vitamin D supplementation. Autoimmune diseases progression and prevention can also be done with vitamin D. Regarding treatment of infectious diseases, it enhances the antimicrobial defenses by stimulating antimicrobial peptides, as we have already discussed, by improving the barrier functions, by immune system modulation, by boosting the innate immunity as well as the adaptive immunity. Impact specific infections, that is respiratory. Higher vitamin D levels are linked to reduced risk of acute respiratory infections, especially the influenza infections. Tuberculosis also has shown a protective effect. Viral infections are prevented. Clinical implications being supplementations can lower the risk and severity of the infections, particularly in populations who are at deficiency. And it can be adjunctive therapy in treating infectious disease processes, especially if it is respiratory. Now, regarding the deficiency and health implications, the causes of vitamin D deficiencies are inadequate sun exposure, which can be due to the lifestyle, higher latitudes, limited outdoor activities, extensive use of sunscreens, limited dietary availability, malabsorption problems, obesity, aging. So, how do we deal with this? The clinical implications of deficiency are skeletal effects with rickets, softening or weakening of the bones in children. In adults, it can result in osteomalacia, that is softening of the bones, bone pain, osteoporosis, decreased density and strength resulting in fractures. Non-skeletal effects like increased infection rates, autoimmune disorders, cardiovascular effects, diabetes, And the global prevalence of deficiency is widespread, which is across all the population groups. High risk being elderly, people with dark skin living in northern latitudes, and people with limited sun exposure. Strategies are supplementation of these high risk groups, dietary fortification with vitamin D, sun exposure, change of lifestyle, and there are some diagnostic markers, the primary being the 25 hydroxy vitamin D. It is the best indicator of the vitamin D status, and conversion and stability is because of the liver and its long half-life. Optimal levels and deficiency threshold is above 30 is considered okay, and 75 it is generally considered sufficient. Insufficient is when it is below 30 nanogram per liter or 75 nanomole per liter, which is insufficiency. And level less than 20 is considered deficiency. So toxicity is when it is more than 100. Other biomarkers being 125, which is very non-reliable though, parathyroid hormone, the calcium phosphate levels. Assessing methods can also impact, that is blood tests, frequency of the testing, clinical implications being guiding treatment. You need to have understanding of the vitamin D levels. The next is personalizing the recommendation of how much supplementation we need to do. So knowing a baseline vitamin D level helps us. Therapeutic uses of vitamin D being the supplementation guidelines. Daily requirement is to be changing based on the age, health status, and sunlight exposure. The general guideline is infants 400 international units, children and adults up to 70, 600 to 800 international units. Adults more than 70 years up to 1000 international units can be taken. Pregnant and lactating, it is 60 to 80, 600 to 800. High risk groups may be recommended for patients who are having the limitations that we have already discussed. In those, we can give a higher supplementation also. Now, forms of supplementation are vitamin D2 versus D3. Vitamin D3 is generally more effective at raising and maintaining 25 levels, and D2, that is plant based and often used in fortified food but is less effective than D3. Oral supplementation in tablet, capsule and liquid drops, intramuscular injections are also available. Therapeutic usage is mainly for treatment of deficiency, that is a loading dose. High dose regimen, that is 50,000 international unit weekly, is often used initially to quickly correct severe deficiencies. Maintenance is 1000 to 2000 international unit daily. Monitoring, regular follow-up and blood tests to ensure target 25 hydroxyl levels are achieved and maintained. Special therapeutic usages for bone health, for chronic diseases, for infection control can also be done. Safety and toxicity, upper limits being generally 4000 international unit is considered safe for most adults. Signs of toxicity are hypercalcemia, nausea, vomiting, renal complications. Monitoring is to be done when you are giving very high dosages. Regarding vitamin D analogs, the purpose of these analogs is to enhance the therapeutic effect, target action. Common vitamin D analogs are calcitriol, alpha calcidol. This is a prodrug which gets converted to calcitriol in the liver. Then you have paricalcitrol, which is a synthetic analog, and then we have the doxorcalciferol, which is another analog which is used for treatment of secondary hyperparathyroidism. So these are the various places where these analogs can be created by changing of the A ring or the SECO B ring or the CD ring or the side chains. Now, vitamin D analogs development and usage, the clinical application is there in bone disorders, for chronic kidney diseases, psoriasis and skin conditions, and cancer therapies. The mechanism of action is similar by selectively acting on the VDR and reducing the calcemic activity. Advantages and limitations, advantages being enhanced specificity, reduced risk of hypercalcemia, and potential for treating wider range of diseases. The limitations being may still be require careful monitoring of the calcium levels. Just because it doesn't increase the calcium level doesn't mean that we don't need to monitor. There will be some calcium changes. So what is the take home messages? The take home messages are vitamin D has an essential role in the bone health and also about the immune function, cardiovascular health, and cancer prevention. The main source is sunlight, while dietary intake and supplementation can also help us. Deficiency is widespread and it is linked to numerous health conditions, particularly in regions with low sunlight and individuals with poor dietary intake. Regular monitoring and tailoring supplementation is key to maintaining adequate vitamin D levels. And there is ongoing research to look at the pleiotropic effects and the therapeutic benefits of vitamin D beyond the skeletal effects, that is, in cancer prevention, in cardiovascular health, and in autoimmune disease prevention, and even in treatment of respiratory infections. Thank you for your patience.